Everyone, welcome to our radiology club. Today we are going to present some nice things. First, we'll talk about adenomyosis, a sonographic diagnosis by Dr. Suad. May she start.
Good morning, everybody. Adenomyosis, a sonographic diagnosis. Introduction. Adenomyosis is a common uterine condition characterized by migration of endometrial glands and stroma into the myometrium. These displaced glands incite spiral vessel angiogenesis and smooth muscle hyperplasia and hypertrophy, leading to thickening of the junctional zone and cause diffuse uterine enlargement when severe. Signs and symptoms. First, pain. Second, menorrhagia, which is the most common symptom, and it is likely caused by increased total volume of endometrial glands in the uterus and or increased myometrial vascularity from the ectopic glands. The dysmenorrhea is the second most common symptom, dyspareunia, and the adenomyosis is thought to play a role in infertility. Reports show an association between an increasingly thickened junctional zone and decreased implantation rate during in vitro fertilization. Higher first trimester miscarriage rates are reported in women with adenomyosis. The prevalence and the causes. The reported prevalence of the adenomyosis varies widely, from 5 to 70%, depending on the method used for diagnosis, with a mean prevalence of 20 to 30%. Previously, when the diagnosis required a histologic analysis and was dependent on hysterectomy specimens, the disease was thought to occur primarily in women in their 40s and 50s. Adenomyosis has been frequently diagnosed in women in their 20s and 30s, with some cases discovered during adolescence. A prospective study in 2015 found a 34% prevalence in nulliparous women aged 18 to 30 years who presented for counseling on contraception. While the exact cause of adenomyosis is unknown, the prevailing theory is that the endometrial gland directly invade the myometrium. Other theories include embryologically displaced pluripotent Mullerian remnant.
So, first of all, you can see that even in nulliparous women, adenomyosis can happen.
Yes.
يعني مش شرط إنه there is cesarean section أو pelvic inflammatory disease or previous deliveries or whatever. It can happen in nulliparous. It can happen in adolescent. So keep that in mind. Even adolescent you can diagnose adenomyosis. Second. Third, what's the difference between prospective and retrospective studies? You know? Because prospective study. شو يعني prospective? What does it mean?
And raw data.
شنو هذا؟
يعني
يعني أقول لك do for me a prospective study. أقول لك make a retrospective study. إيش راح تسوي؟ What difference does it make?
the data is collected from the يعني previous raw data.
مال شنو؟ Which retrospective شنو هي؟ Retrospective is looking at the hospital records.
Yes.
Patients are diagnosed,
Raw
treated,
data.
and discharged, and everything is done, or he's dead. Everything is done, and you just go through the records, collect them.
Yeah.
Prospective, لا. You have like 20
Collecting
patients and you follow them up.
the data, yes.
Prospectively, you see what will happen with them.
Yes.
Okay? So there's a difference, big difference between prospective and retrospective. Okay. Well, according to them, let's see. We'll see.
Invagination of the endometrium along the intramyometrial lymphatics. Categorization of ultrasound findings in adenomyosis. First, a globular uterus or asymmetric myometrial thickening, heterogeneous myometrium with a thin Venetian blind shadow between the areas of increased echogenicity. Myometrial cystis, indistinctness of the margins of the endometrium and echogenic linear striations, and nodules extending from the endometrium into the myometrium.
شنو الفينيشيال بوينت تعرفين؟
Layering.
What's Venetian blind?
خيمة.
بردة. curtain.
Yes.
Okay.
Curtain. Yes.
هاي يستخدموها بالمكاتب اللي يجي تجرها layers and it goes up and goes down.
Zebra. Zebra.
It's something like zebra, yes. So it looks like them, maybe. Lines.
Yes.
Dark, bright, dark, bright, dark, bright. Okay.
Myometrial cyst striation. Sagittal grayscale transvaginal ultrasound image shows lollipop diverticulum extending from the endometrium into the anterior myometrium. This one. The endometrial myometrial border is completely obscured. We cannot differentiate between the endometrium and myometrium. Muscular hyperplasia and hypertrophy. Since the ectopic endometrial glands remain hormonally sensitive, resulting in the myometrial smooth muscle hyperplasia and hypertrophy. Myometrial thickening can be focal or diffuse, although focal areas have relatively indistinct borders compared with those of leiomyomas. The uterus may remain normal in size, demonstrate asymmetrical myometrial thickening, or develop diffuse globular enlargement. Asymmetric adenomyosis most frequently involve the fundal region, less frequently the anterior wall alone, and rarely the cornu or near the cervical os. While the classical finding of the junctional zone thickening at MR imaging can be appreciated at ultrasound, we have found that precise measurement of the junctional zone are more difficult to obtain and are less helpful at ultrasound. Equally important to the thickening is the altered echotexture of the myometrium, which becomes heterogeneous and coarse, with thin vertical shadows resulting in a Venetian blind appearance. The combination of the heterogeneity, thin shadows, and the small hyperechoic nodules and striation gives an appearance of like to the ultrasound appearance of the end-stage liver disease and described as cirrhosis of the uterus. Stromal muscular hyperplasia.
So you know what's cirrhosis of the uterus?
And hypertrophy in two patients. A sagittal grayscale transvaginal ultrasound image shows diffuse bulkiness, heterogeneity of the myometrium. And here, second figure, sagittal grayscale transvaginal ultrasound shows focal adenomyosis in anterior uterus with asymmetrical thickening of the anterior myometrial heterogeneity, pencil thin posterior shadowing, those. And here we have focal adenomyosis in a 46 years old premenopausal woman. Sagittal grayscale shows a round mass.
Adenomyoma.
Yes, and the sagittal T2 weighted MR image of the pelvis shows adenomyoma on a background of the diffuse adenomyosis. About the vascularity, in adenomyosis, the myometrial vascularity is generally increased owing to muscular hyperplasia and hypertrophy. The color Doppler ultrasound pattern of the adenomyosis consists of an increased number of tortuous vessels that penetrate throughout the involved myometrium. This type of vascularity is distinctly different from the pattern typically seen with leiomyomas. Thus, color Doppler ultrasound is helpful in distinguishing focal adenomyosis from leiomyomas, which tend to displace vessels and demonstrate circumferential flow. Here, vascularity in two patients. Figure A, sagittal grayscale transvaginal ultrasound image shows abnormal myometrium with focal heterogeneity, small echogenic nodules, and tiny cysts in the posterior myometrium. Here. With poor visualization of the endometrial myometrial border. This is typical of adenomyosis. And the second, sagittal transvaginal color Doppler ultrasound in the same patient, as in it shown increased density of the vasculature with numerous tortuous penetrating vessels. And this figure is
So it should be the whole uterus.
whole, yes,
Because the whole uterus is rotating.
involved, heterogeneous.
More in the mass, but the whole thing is showing.
It's not a focal adenomyosis, it's a focal.
Even if you notice, there are some cases here that are combination of diffuse with focal adenomyosis.
And here we have a sagittal grayscale transvaginal ultrasound of different patients, discrete heterogeneous lesions typical of leiomyoma. Here.
So you can appreciate the difference between the vascularity in leiomyoma and fibroid and vascularity in adenomyoma.
Yes.
Adenomyoma is more vascular, it's more heterogeneous, more widely distributed, while leiomyoma, the fibroid, is a mass that just extends the whole thing, displaces everything. Just like the thyroid nodules, you see the nodule pushing the
Yes.
vessels rather than.
And color Doppler image of the same patient shows leiomyoma, which can differentiate from the focal adenomyosis but by its peripheral vascularity. Atypical cause and mimics of adenomyosis. First, tamoxifen. The ultrasound appearance is similar to that of the spontaneous adenomyosis, in which the affected endometrium contains cysts and echogenic stroma, making it difficult to measure the endometrial thickness. Here, there's blurring of the endometrial myometrial interface and multiple inner myometrial cysts. First.
Transvaginal ultrasound, 39-year-old, single focal lesion of adenomyosis in the anterior fundus.
Yes.
So it's an adenomyoma.
Yes.
Not no,
No,
just I
general.
think comparing. Let's see. Fundal
At
endometrium.
fundal area, yes. Obscuring the adenomyosis. This adenomyoma that obscuring the adenomyosis.
Show again, Bola. Can you just explain this to us?
Sagittal grayscale transvaginal ultrasound image of the uterus shows single focal region of adenomyosis in the anterior fundus. And note how the fundal endometrium is obscured by the adenomyosis, while the more inferior endometrium is well depicted. And figure B, coronal three-dimensional reconstructed ultrasound image in the same patient show two areas of focal adenomyosis in comparison with the adjacent normal myometrium. Yes, and this is normal. And
It's just aiming to differentiate between the adenomyosis and the effect of tamoxifen. You can see in A and B, this one is A and B, and C and D, okay? This is adenomyosis, and on 3D reconstruction with ultrasound, okay? You can see the rest of the endometrium is well seen, while the area of adenomyosis is obscuring the endometrium, okay? And on the 3D reconstruction, you can see areas that are relatively ill-defined. While in this patient, the one with the endometrial cyst, due to tomography, the whole endometrium is not very well defined, and there are myometrial cysts. And on the 3D, you can see the whiskering. It's like Schwarber. Okay? Good. Yeah. Next.
Endometrial ablation. Endometrial ablation is the procedure performed to destroy the endometrium in women with perimenopausal menorrhagia using thermal, cryo, or radiofrequency and microwave ablation. And, yes. Deep-infiltrating endometriosis is defined as extension of the ectopic endometrial glands more than 5 millimeters beneath the peritoneal surface. The ultrasound is the same as a classic inside-outside adenomyosis, with heterogeneity, small echogenic nodules, echogenic striations, and myometrial cysts, but with a normal endometrial myometrial interface and without thickening of the inner myometrium.
Definition of the endometriosis? The endometriosis goes outside the end of the uterus into the peritoneum and invades the uterus from outside, not from inside. Inside it's adenomyosis. From outside, from the period. It's so interesting. Good.
Leiomyomas. Patients with a leiomyomas and adenomyosis frequently present with similar symptoms such as uterine enlargement, menorrhagia, dysmenorrhea, and anemia. The findings at the ultrasound can similar as well, particularly in cases of focal adenomyosis. Accurate differentiation of these two entities is important because the most effective treatments for the leiomyomas and adenomyosis differ. Because leiomyomas has a pseudocapsule, it manifests as a discrete, well-marginated mass, often with a hypoechoic, spheroid appearance, with focal adenomyosis has ill-defined borders. And other hyperfeatures of characteristic of leiomyomas are the presence of calcification and focal bulges in the uterine contour. And this figure shows a difference between the adenomyosis and leiomyosis characteristics. Shall I read?
Okay.
Uterine contraction. A uterine contraction can manifest as a focal hypoechoic mass-like area in the myometrium that can be mistaken for a leiomyoma or focal adenomyosis. Contractions can be differentiated from the true myometrial disease by their transient nature. This is two figures of the same patient in two different times. This is uterine contraction.
Yeah, I think anyway.
Because sometimes we see this feature is with the pregnancy. From
Yes.
first trimester.
Yeah,
We may miss with the fibroid, maybe.
and that's why she's already at two different times.
Yes.
Contraction and then it disappears.
Yes, or maybe contraction. This is not, at least not anything, it's contraction, maybe.
Yeah,
Why not?
exactly. Yeah, هذه contraction. This is contraction. Even in
It's a
non-gravid
differential.
uterus can't be a contraction.
Yes.
Another differential is neoplasm. If the endometrial cancer invades the myometrium and obliterates the endometrial myometrial interface in a fashion similar to that of adenomyosis. However, endometrial cancer typically cause endometrial thickening with area of focal color flow at color Doppler ultrasound. In the setting of adenomyosis, the endometrial thickening and flow should remain within normal limit. The extension of the malignancy into the myometrium is usually more lobulated and mass-like, as opposite to the thin striation and small echogenic nodules seen in the adenomyosis, which it is difficult to distinguish between a minimally invasive endometrial carcinoma and adenomyosis.
And if you see this, you'll think of adenomyosis. However, I think after biopsy it was شو اسمه يعني endometrial carcinoma. Findings presenting endometrial carcinoma with a myometrial invasion. So it's difficult to differentiate really between invasive endometrial carcinoma or adenomyosis. Not that easy. And this is the most most common sense, endometrial carcinoma is in postmenopausal, presenting with recurrent vaginal bleeding. But if you have this in a premenopausal, then you have a difficulty in differentiating things.
Such color doppers usually.
Of course, the color Doppler is of much help here, however. Okay.
Vascular malformations. Vascular malformations appears as a focal area of heterogeneity in the myometrium with the multiple hypoechoic and anechoic spaces and ill-defined margins, similar to the adenomyosis. However, a vascular abnormality will not disturb the endometrial myometrial interface. The most diagnostic feature is the pattern of flow. At color Doppler ultrasound, the cystic spaces fill with a pixel of alternating blue and red flow, and the spectral Doppler demonstrates a turbulent high-velocity flow with low resistive index.
Again, just like your
Yes.
color Doppler is
Yes.
amazing. Multiple vascular channels that fill with low resistant pattern waveform and marked vascularity. Yes.
Yes.
Why about it?
Conclusion. Transvaginal ultrasound is now the primary imaging modality for the diagnosis of adenomyosis, and its widespread use has allowed for a better understanding of the scope of adenomyosis in premenopausal women for all ages. Transvaginal ultrasound can be used to confidently diagnose adenomyosis in a majority of cases, particularly if multiple ultrasound findings manifest. Specific histologic-based criteria aid in the ultrasound interpretation and includes findings related to the ectopic endometrial glands and stroma, myometrial hyperplasia, hypertrophy, and increased vascularity. Advanced ultrasound techniques, including obtaining two-dimensional and three-dimensional coronal reformatted images and cine clips, and performing saline infusion hysterography can be used to corroborate standard ultrasound findings, especially when coexisting leiomyomas or endometriosis manifest.
Nice, thank you.
Thanks.
So good.
دكتور فعد السلايد مو بيشتغل. دكتور, this slide sometimes this is similar to the uterine tear if it is in the early sac equal to the 3 to 4 millimeter. This picture sometimes similar to the uterine tear if she has previous cesarean section.
Here, it's not in the location. You mean in
Something
the
like
scar?
that.
In the cesarean scar? You mean? In the cesarean scar. Right?
Yes.
But it's usually the cesarean scar is in the lower uterine segment, not upper. This is in the fundus.
Sometimes uterus is retroverted. It's not like that's antiverted always.
It's okay, says that.
Okay.
That's
But you should have a history of positive pregnancy test, previous cesarean section,
As a picture.
acute bleed. As a picture, yes.
Marble is clear,
Yes.
hygienic marble.
Yes. This is
Around the
typical picture.
Nice. Thank you. So, next we'll have Science in Radiology by Dr. Shanga. Let's see what she prepared for us.
Good morning, everyone. Science in radiology, particularly science in chest X-ray. I concentrate on this part because as a primary, we face a lot of difficulty during reporting.
Good.
So the first sign is this
What's
sign.
the sign? What? Start with that. Fallen lung sign? Is it?
Yes.
Good.
This is CT.
So what's fallen lung sign?
Fallen lung sign is sign referred to appearance of the collapsed lung occurring with the fracture bronchus, especially during the iatrogenic during bronchoscopy. The bronchus will be ruptured, so the collapsed lung collapse away from the hilum.
Yeah, it falls.
Falls away from
Position
the hilum.
dependent.
Yes.
With the gravity, you turn the
Yes.
patient to the right, it goes to the right. To the left, it goes to the left. Because the bronchus is teared, ruptured,
Yes.
fractured. So it's fallen one. And the important thing here is when they put chest tube, nothing happens.
Yes.
Air comes from the chest tube, but still pneumothorax still
Yeah.
collapsed because bronchus تحطها chest tube طلعها. No inflation will happen. So it's an important
Yes.
sign to know about.
Either this falls either inferiorly or laterally in upright patient or posteriorly in the supine patient, according to the gravity. It should be differentiated from the pneumothorax. Collapse will be toward the hilum.
If there's no fractured bronchus,
Yes.
the collapse will go to the hilum.
Hilum. Yes.
If the bronchus fracture will fall away from the hilum. Okay? Good.
This is another sign
Now,
And
what
then-
do we have here?
in the infant.
This is a very, very young age child
Yes.
having some sort of opacification in the upper chest, which is the thymic gland. What we call this sign? Cell sign?
Cell sign or
Cell.
spinaker signs or
Spinaker.
angel wing sign or cell sign.
Angel wing sign.
Yes. It refers to the thymus being outlined by the air with each lobe displaced laterally, appearing like spinaker cells. Due to the when there is the air in the in the mediastinum, this will
Well, it's
surround.
different from the cell sign. The cell sign is a normal sign. You have to be
This is
careful here. Cell sign is something normal.
But not such big يعني.
Exactly. What you are talking about, the angel wing or spinnaker sign, it's a
Nemo
disease sign.
mediastinum. Yes. Other signs, yes.
Exactly. She will explain it to us. Just
This is
explain.
the spinaker signs. There is pneumomediastinum surrounded, surrounding the thymus lobe.
Thymus can become elevated, creating a thymic cell sign or spinnaker sign. Well, he's not differentiating between the two, obviously. Can be, yes.
This is
Okay.
another sign.
What do we have here? What's the
Arrow is directed to it. The arrow.
Fusion pneumothorax, mild fusion.
No.
Ventilation.
Hampton Hum sign.
زي شنو عرفتها الصورة من الصورة؟
لا, Hampton Hum signs is a wedge-shaped pleural based consolidation with rounded convex apex directed toward the hilum.
Good.
This sign was first described by the Hampton, and it is usually encountered in the lower lobe and healed with scar formation. The first is, I think, is embolism.
Yeah, sure, it's secondary pulmonary embolism. With secondary pulmonary infarction. You see there is a hump. However, it's, and in the CP angle, it's difficult to say this is a Hampton's hump. Usually you see it on the lateral chest wall more. The second image is more typical than the
This-
first one.
yes.
Yeah, this is a really good Hampton hump.
Yes.
Done.
But
Wedge shaped, peripleural based, peripheral towards the hilum, suggesting pulmonary embolism. Okay.
this is what I have.
Very good. Nice, thank you. Nice signs. And third we have Dr. Abikhal will present to us differential diagnosis of liver ultrasound something.
differential diagnosis of liver ultrasound: generalized increase and decrease echogenicity and hypoechoic and hyperechoic mass in the liver. In this picture, you have a normal liver with a transverse sections of a normal liver, portal veins going to inferior vena cava, left lobe of liver and a caudate lobe, left lobe and a right lobe of a liver, just a normal picture. Generalized hypoechoic liver. Differential diagnosis of generalized hypoechoic liver. It may occur in acute hepatitis. Usually in mild hepatitis is normal, but in acute hepatitis we have a hypoechoic liver, mostly due to accumulation of fluid in hepatocyte and more echogenic portal veins walls that appear as a starry sky.
The starry sky pattern, you can see it here in
Yes.
acute hepatitis due to liver edema,
Yes.
result in increased the echogenicity of the portal triads compared to hypoechoic liver background.
Yes, this is a hypoechoic background, and also there will be thickening of gallbladder wall, also due to the edema. And other cause is a diffuse malignant infiltration. Actually, I didn't find the picture for this. Generalized hyperechoic liver. The first and most common is a fatty infiltration.
Yep.
We have the 3 stages of fatty infiltrations. The first, which is a mild steatosis, which is a minimal increased hepatic echogenicity with a normal vasculature appearance, normal appearance of a diaphragm. While moderate steatosis is more increased echogenicity with a slight impaired visualization of portal veins, of the vascular appearance and the diaphragm, and the severe steatosis, which will be no visualization of diaphragm and the vascular within the liver with increased echogenicity. And the second is a cirrhosis. Cirrhosis also other cause of the generalized hyperechoic liver. As we see in this picture, this is a volume restrictions, smaller, as a liver will become small, with a caudate lobe also is present here. And then it become coarse texture, then may have a lobulated outline, and then in the end stages we may have a regenerated nodule which appear hypoechoic.
And here is the problem. Which one is the regenerated nodule? Which one is hepatocellular carcinoma?
Yes.
That's the problem. Okay.
Chronic hepatitis. In acute hepatitis there will be generalized hypoechoic, while in chronic hepatitis there will be increase in echogenicity and then go into the stage of cirrhosis. And hepatic TB is another cause.
Hepatic TB is another cause of what?
Increased generalized increased echogenicity. Yes, this is all is a differential diagnosis of generalized increased echogenicity. Glycogen storage disease. And you come to the focal masses. Focal hyperechoic. Differential diagnosis of focal hyperechoic. Metastasis is one of the causes. Metastasis could cause the focal hypoechoic or hyperechoic also.
But I think the vast majority is hypoechoic.
Yes, and there is a difference.
99% of the times the metastasis will be hypoechoic, and hyperechoic lesion will be considered as a hemangioma rather than a metastasis.
Right.
Not always, but
Yeah,
in
it's
some vast
maybe
majority. Okay.
it's okay.
Continue.
Capillary hemangioma, adenoma, focal nodular hyperplasia, focal fatty infiltration, debris within the lesion, sepsis and hematoma, and hepatocellular carcinoma. Also, hepatocellular carcinoma may cause hypoechoic and hyperechoic. This is a picture showing the metastasis, multiple echogenic nodule lesion due to hepatocellular carcinoma metastasis. Bullseye appearance is one of the signs.
Bullseye appearance.
Yes. And this is a hypoechoic also, that may cause hypoechoic also. This is a hemangioma, which is well-defined echogenic mass, most common benign tumor of the liver.
But I can't hear you.
Oh, really?
When we
I'm shouting. Okay.
Okay.
Well-defined echogenic mass is the most common primary tumor of the liver, which is a benign, of course. Focal nodular hyperplasia. Although it appears isoechoic in these pictures, appears echogenic. And the things in the focal nodular hyperplasia, we have a central scarring, which is appearing here. And adenoma, also it is a well-defined echogenic mass, may be seen in the liver.
This one, which image is this color or
What?
is it flower or third bodies?
This?
No, no.
Big
Up.
puppet or which kind of machine?
It looks like some sort of a color Doppler, but
I think it is zooming, just
Just zooming or
zooming.
no, it contains is making bright.
it looks like a vascular color, but outlining the star. Maybe shear wave? Something like shear wave?
Elastography means elastography gives blue and red and
It's a
green.
strange appearance. Anyway,
Maybe
I don't
flow.
know.
Maybe flow.
Maybe. Okay.
Okay. Multifocal steatosis, also we could say as a differential diagnosis of echogenic mass.
Steatosis is fatty liver.
Fatty liver, yes.
Okay. This-
Focal fatty liver.
So multifocal is a multifocal distribution of fatty infiltration.
And also it spurs a segment 4, that's very hypoechoic. Here.
يعني focal fatty sparing.
Yes.
Usually at the gallbladder bed.
We have pseudosteatosis.
شو جاينا؟ شو السودوميديروس steatosis? I didn't get it.
Echogenic nodal segment.
4D to the bifurcation portal of vein.
Focal nodal in the MRI exam.
Uh-huh.
Here.
Where is it? Can you say what you know?
This, I
Yeah,
think.
just like here.
Yeah.
Some increased echogenicity. They did an MRI and it was appeared to be fatty
Just fatty.
infiltration, focal
Yes.
fatty infiltration.
Hepatocellular carcinoma. Here's the lobulated. Here's hypoechoic in the periphery of right lobe. Hypoechoic lesion in the segment 4. Here.
Background
Yeah.
is cirrhotic liver with a big lesion that appears hypoechoic. It has internal vascularity,
As we
mainly
say,
arterial. If you can see the pulse with the spectrum.
peripheral vascularity.
Okay, and you can see the portal vein is patent.
Yes, hepatocellular carcinoma, as we say, can be
Portal vein.
echogenic
Tumor
or
of thrombus, not
hypoechoic.
tumor of thrombus. What's tumor of thrombus?
Tumor thrombus is a part of the tumors that is invading into the vessels and like
So,
emboli. It
It's
appears
not
like
the
emboli.
usual thrombus. Usual thrombus. Thrombus,
Blunt.
exactly, blood thrombus, occluding the vessel or the vein. Tumor thrombus, the tumor itself
Tumor
goes
cells,
into the vessel
yes.
or the vein. So you can see vascularity in the soft tissue mass of the thrombus.
Okay.
And it indicates that the tumor is inoperable.
Focal hypoechoic mass is a differential diagnosis of focal hypoechoic. As we said previously, metastasis could be hypoechoic.
Because,
Yes.
multiple hypoechoic liver masses or
Mostly
lesions.
metastasis.
Number one differential diagnosis is
Metastasis.
number two
Hepatocellular.
metastasis. Number three metastasis. Can be metastasis.
Okay.
Okay?
Okay. And the mostly hypoechoic from ovary, pancreas, stomach, colon, as in this picture, which is a pancreatic metastasis. Lymphoma, with other causes of hypoechoic lesions. This also appearance like a metastasis.
Okay.
Um,
What else?
hepatocellular carcinoma, as we say previously, and abscess, which appear in thick walls and with internal debris mostly. And we have a hydathocyst.
Hydathocyst in different variable stages.
Yes.
We all know the stages. Well, it's a common disease in our area. However,
Yeah,
outside they consider it like a big diagnosis. I have a case of hydathocyst. You see that?
it's too much here.
Yeah.
Yeah, different stages. The first stage, which is a thin walls. As a stage 2, there will be small cystic within it. And the third stage, there will be detachment of the wall, what's called the water lily sign. And in the fourth and fifth stage, it may appear as a heterogeneous mass that may be difficult to be differentiated from the tumor. It's appearing like tumor. In the first stage and second stage, it is active, and in the fourth and fifth stage, it's inactive. And thank you.
Thank you very much. Any questions? So,